Ashley, and good morning everybody. I'm really delighted to be here and welcome you to our city. I hope you've managed to enjoy it last night and today and get some time. I have had the real privilege of being the Director of Public Health for 14-15 months now in Newcastle, as well as the Deputy Director during the pandemic. So you may have spotted I'm not from here, but I have really seen in the last few years the exceptional character of Newcastle. We've got an incredible health system, not just in terms of our outstanding trusts and the academic institutions, but we've got real character as a community. They're very hardworking, very generous, very tolerant residents in Newcastle, and I think that's shone through, particularly in the last few years, and especially during the cost of living pressures that we see as a system at the moment. So I'm just going to talk a little bit about Newcastle in terms of our public health context, and some of the things I think we need to think about as a wider public health community, and how Newcastle's situation hopefully translates, and there's some learning for us all in that context. It's particularly important for Newcastle to be having these conversations and make sure myself and my colleagues are articulating what a public health approach means, because we are delighted to have received NIHR funding for the Health Determinants Research Collaborative this year, and we're on a journey. And what I'd say is, while it seems very obvious to public health professionals why public health sits in local authorities and the opportunities we have, I'm taking nothing for granted in terms of my local authority colleagues understanding that the scale of the opportunity we have from that grant and what a public health approach means. So stolen from my DPH report, so it is mine, but it's repurposed for today. This is a map of a Geordie life, of the average statistics around a range of health and social indicators, and I particularly wanted to highlight social indicators because it is a document that is speaking to our residents, but also speaking to my colleagues, not to public health professionals. And I wanted to really make sure it wasn't a document for us in terms of our interests. So everything that we know in terms of our evidence base of, whether or not you own your own home to whether or not you finish school with qualifications is of course important. But what I'm really mindful of in terms of our use of data and statistics is there is no average life. So this is the average life, but what we also know is the distribution of disease, illness, health outcomes is not equal. So nobody has this life. What this doesn't reflect is our variation, and that's where we need to focus, because we know that the children who don't receive their immunisation are also those more likely to struggle in school and more likely to be more at risk of substance misuse. So I think our role is to use these data to explain and sometimes be very explicit about why we're highlighting these data. For example, if we took proportion of teenage mothers, that in itself, and using that statistic, can be used to stigmatise or to otherize, or to just be used as implicitly a negative in terms of our standing relative to others. But actually, the reason that's important is because all our knowledge and evidence tells us that young mother is at risk of income inequality, of barriers to employment, to education, at risk of social isolation, less likely to breastfeed. And that impacts her life course as well as the child's. And I think that's often what we need to be very unashamedly empathetic about, is that's why it's important. And that's why we're describing people in this way, because people know how we describe them. That's what's really struck me in terms of the pandemic. There's a huge appetite and interest from our communities in public health knowledge, and our responsibility in terms of public health literacy is not to distance people from these data, but to empower them with describing what that actually means and why it is important we use these data. So these are both pictures of Newcastle. They're about 15 minutes apart. Some of you might have seen the beautiful quayside I showed on my first slide, and you might have seen the leafy, lovely parts. These are quotes from residents. And it just strikes me as, if you're in a privileged role and if you are part of the public health community, you work in the hospital or the universities, often what I hear is it's such a lovely place to live. Low house prices, leafy green, you can cycle into work in 20 minutes. What a nice place to be. However, if you're also part of the public health community, you might say, gosh, we've got the worst health outcomes in the country. The North East is known for highest drug-related deaths, for our smoking prevalence, for our low life expectancy. And in Newcastle, we've got 43,000 food bank users out of our 300,000 residents. So people's experience is very different, a mile apart. And I know within the public health community, we talk about the inequalities in a very factual way, but it almost dulls our outrage. That's not okay, because for me, the inequality in itself demonstrates the potential of where we should be. There's absolutely no reason that everyone can't enjoy Newcastle being a green city, a friendly city, a city you can walk everywhere to. And that's the real challenge I hold up to myself and my team. So some boring health statistics just to prove that in themselves, they're not helpful. So these are just the 5 most common causes of premature mortality, so before the age of 75 in Newcastle last year, and also the most common causes of chronic diseases. There's probably no surprises there, especially if you're familiar with the North East epidemiology, but I guess the take home for me is they're all socially patterned, and arguably, although there's possible exceptions, they're all related to the 4 health behaviours, and we know loads of information and evidence. And I suppose what we also know is they're all preventable. We're drowning in evidence about how they are linked to causation and how all 4 of those behaviours are also tools for intervention and for secondary prevention. And what we need to stop doing, I think, as a public health community is describing the problem, because people don't see themselves as someone with ischemic heart disease or someone with diabetes or someone at risk of diabetes. And we saw that in the pandemic. People see themselves as a mum, see themselves as someone tired, see themselves as a carer. And often people who are in one of these categories will be in another one of these categories. And we all know the likelihood is, so will someone in their household, in their family, in their generational history. So my challenge is really, do we just accept this? Of we've just got really poor health outcomes, and these are the things people will die of and be ill of for a long time. So I think that's my real challenge is it's a distraction to focus on the health outcomes, because currently, you'll all know in terms of the media, the national conversation, we're arguing over how many GPs we need or how many new hospitals we need. And the elephant in the room is we're sicker as a population. It's not about treatment and care, it's about prevention. So for each of these elements, what we need to think about is if you are overweight or obese, you have limitations, you've probably got more absence from school or work, you might live in pain, you might live in shame, you might have low well-being, you might feel isolated. That's the person behind that statistic, and that's where we need to take the conversation, because then we start to look at solutions within the wider determinants and not within the health system. And that for me is the real challenge. If these are important, and we do need to compare them, but to prompt action where it actually makes a difference. We can't cope with these pressures right now, and actually there's lots of ghastly diseases we want our health system to focus on that aren't preventable, or not yet anyway. So just very briefly, this is Newcastle's population pyramid. Public health colleagues will be familiar with, we use pyramids for various reasons. You'll spot we have a young age profile, and often population pyramids are used in order to plan services, and sometimes when we're doing worse than the rest of the country and things, explain and interpret data. So, you know, this was wheeled out as to why we were the worst in the country in COVID vaccine uptake, and it was because we didn't have anyone eligible yet. we were a young population, we've got lots of students. But actually, if we just not think about how we're using it, and we just looked at this tells me, and it's my challenge to myself, of we're younger than most of the country, and youth is associated with economic activity, ambition, vibrancy, and good health. unfortunately, what we've got is long-term morbidity and sickness. So actually, people become iller younger, and that's all to do with the life course that they're set on, often before they're even born. So that's my challenge to my team is, why do we strive to be like the England average? Let's be the best in the country because we're the youngest in the country. So, to counter the population pyramid, this is again a graphic that I developed for my DPH report published in January. And you will have seen similar infographics, but this is about if we were a toon of 100, and the toon is the shorthand for Newcastle, for those who don't know. Because I do think we sometimes forget public health as an art and a science, and we focus a lot on the science. And as someone who's in awe of the brilliance of my academic colleagues in the room, I have had 4 years of doing good enough and being very uncomfortable with it. But a lot of that is the art of the applied public health, of actually how we get things done and what we do. So the idea of the toon of 100 is obviously we don't just describe data points and people as statistics. This is trying to encourage empathy and context, because if we were a wee village of 100, we might have a bit more understanding of someone's lives. So I have banned the term hard to reach in my team. People aren't hard to reach, they're right there. They're maybe not shouting up and down about their health because they're living their lives. They're underserved, and we're failing them in how we present them. So just as an example, if we were a wee village of 100 and we had 17 of the village living in fuel poverty, we wouldn't just think, oh, fuel poverty is on the cold days. And I've colleagues who are very experienced, very senior across the system have said when it snows, oh, fuel poverty will be a problem today. We've got fuel poverty problems as an annual issue, and it's everything from people who use food banks have stopped asking for vegetables that need cooked because they can't turn the gas hob on. What contents can be consumed cold. We've had families with infants in the house who have no hot water and no ability to heat water. So when we talk about fuel poverty, if you actually knew that family in the village, and it was 17 of the 100 of us, you would know it's not about the cold days. It's about we've got community washing machines because people can't put the washing machine on in their own house. And I think what I really try to convey is it's not that in itself, it's how that makes people feel, because that's actually the difference. If you don't feel you're in control, if you don't feel you matter, if you don't feel you value, then why would you actively make health choices if you have any in front of you? So that's what I really tried to get across with this, of what are the social norms and expectations of our community. And this is, and apologies, it's not the clearest slide, but we all know this. So I guess what I've tried to describe is, we focus on health outcomes and use that as our measure. And we can relate them back through evidence very easily to what are the health behaviours. And we can say, well, these are the things that cause them. But this isn't related to how people think. What struck me, particularly through the HDRC work, is this isn't implicit to people. People don't think like this. But if that was your kitchen, you might take the kids out for a McDonald's because your landlord's not returning your calls and they won't fix the cooker and you can't clean it. And then over time you're overweight, and the narrative is you need to make better choices. So again, I just think we should be unapologetic in reminding people this is all in our heads and this is how we see the world, and they don't, and they really don't, in terms of professional colleagues in working across the wider determinants of health. So I'm conscious of time, and I'll just, on this last slide, this is a product of, and apologies, it's not, the text is small, but this is a product of my frustration at everyone now wanting to work on inequalities, and they all think they're doing inequalities and it's a buzzword, and we've got a lot of capital in inequalities, which is great, but we need to be specific about which inequalities, who's positioned to actually influence them, and where are they? Working with ICB and NHS colleagues, they're absolutely desperate to work on inequalities and address them, but them pedestrianising our city or trying to influence that isn't where we need them to work. So this is just a framework, and I'm happy for these to be shared in terms of social inequalities, health inequalities, which are our outcomes, and then healthcare inequalities. and they're quite different in terms of who's positioned to influence which ones. So I guess my ask is that we really consider the data and statistics we use to describe our places, our city, our communities, the people who we're actually here to serve, and think about who is actually placed to interpret, to examine, to explain, to influence, by joining data and working together through jointly asking the right questions and forming the right opportunities and interventions. So be unapologetically explicit. I have learned people do not know what they mean when they say inequalities. They don't know why a statistic is important and what it means. So that would just be where I'd end.